Okay, we're back for the second section of Chapter 10 on cardiology. And we are talking about chest pain. So in the management of the symptoms of chest pain, nitroglycerin and rest are often used to relieve this chest pain, and this also will imply some stable angina. Chronic anginal pain is typically a short duration, usually from 3 to 5 minutes, but may last up to 30 minutes or longer. Nitroglycerin may be given as sublingual or a spray and should be given under the tongue every 5 minutes for up to 3 doses. If pain has not been relieved after 3 doses, EMS needs to be contacted to transport the patient to the ER. After the chest pain has been relieved, a beta blocker or a long-acting nitrate may be prescribed to decrease the myocardial oxygen demands. All patients that are diagnosed with angina should be placed on a daily aspirin regimen to prevent a thrombus. With unstable angina, the goal is to diagnose the underlying condition and treat appropriately if rest and nitro do not relieve the chest discomfort. The patient needs to be transported to the nearest ER for evaluation. And on page 467 in your book, you can see a flow chart for the management of unstable angina. For variant angina, also known as Prinzmetal's angina, it's an atypical form of angina that occurs as a result of a vasospasm of an otherwise normal coronary artery. Pain is experienced at rest and seen on EKG when taken during an attack. You will notice an ST segment elevation rather than a depression. So a calcium channel blocker such as a verapamil is used for treatment. The goal and management of an MI is to salvage ischemic myocardium before it becomes necrotic and offer reperfusion as soon as possible. After that goal, then you're directed at preventing future attacks. So if there's concerns for an MI away from the hospital, it's important to have the patient rest, chew and swallow 325 milligram aspirin, and call EMS to transport to the ED. The next thing we're going to talk about is heart failure. And heart failure is a condition where the output is insufficient to meet the body's needs. And there are several types. We've got systolic versus systolic versus diastolic, right-sided heart failure versus left, right ventricular versus left ventricular failure, and then forward versus backward failure. Each patient presents differently because of their various causes and stages of heart failure. Left ventricular failure presents with symptoms of pulmonary origin due to the backup of pressure in the pulmonary arterial system. Right ventricular failure systems occur as a result of hydrostatic pressure buildup in the venous system. So with the right ventricular failure, you may see systemic edema. Heart failure has become just a very general term to describe all types of conditions and where the cardiac supply is less than the metabolic needs. And it's important for these patients to have easy identification and patient education to help prevent the disease and improve quality of life. So on clinical presentation, with the pulmonary system, you may see cough, orthopnea, dyspnea, and paroxysmal nocturnal dyspnea, so shortness of air when at nighttime. Central nervous system present symptoms, you may see delirium, insomnia, anxiety, headache, hallucinations, and unresponsiveness. You will notice some generalized systemic and organ systems that are impacted. You may see fatigue, weakness, decreased urinary output during the day, nocturia at night, peripheral and dependent edema, nausea, vomiting, constipation. Some diagnostic tests that are used would include your B-type natriuretic peptide, your BNP. This peptide is abundant in the heart and rapidly rises in the bloodstream in the presence of heart failure. BNP is a cardiac marker that can be used in combination with other definitive tests and is not solely relied on as a diagnostic test for heart failure because it can be elevated in pulmonary edema, COPD, PE, and renal diseases and other conditions. However, for the BNP is greater than 500, it is highly indicative of heart failure. An echo is the single best test to confirm the diagnosis of heart failure. and it will determine abnormalities found in systolic or diastolic function, and it will visualize the ejection fraction and give an estimation of how well the heart is pumping. Although there is no specific EKG pattern to diagnose heart failure, an EKG may be helpful in diagnosing the underlying causes, such as an MI. And a chest x-ray may show alterations in cardiac silhouettes as evidenced by changes in cardiac size and shape and the change in the cardiothoracic ratio. It may also show some pulmonary venous congestion. So we have the New York Heart Association classification of heart failure severity. There's 4 classifications at the bottom of the slide. We have the link for that, so you can go and check that out. Level 1, stage 1 is patients that are asymptomatic with heart failure. 2 is patients with heart failure with symptoms with significant exertion. 3 is patients with heart failure symptoms with minor exertion. And 4 is patients with heart failure symptoms at rest. Here's a snippet from their website that also talks about further the classifications and some of the symptoms that you may see on that. So for the staging of this, you need to identify patients that are at risk for developing left ventricular dysfunction and having patients with dysfunction who have not developed any symptoms, and also noting patients with left ventricular dysfunctions that have symptoms, and then patients with refractory end-stage heart failure. One of the most important reasons why you classify these patients is it helps to determine what treatment goals you are going to want to choose. So for management of heart failure, these principles include identifying and treating precipitating factors or anything that is causing an aggravation of the condition, and also important to recognize underlying cardiac diseases and manage the cardiac failure. So the management includes decreasing the cardiac workload, decreasing the clinical volume overload, optimizing LV function, reducing mortality, and controlling AFib. So to reduce mortality, the providers should order ACE inhibitors, which are indicated for all patients with LV systolic dysfunction unless there is a specific contraindication. This medication is considered the cornerstone of heart failure therapy, and ACEs have been shown to counteract many of the neurohumoral changes of heart failure and therefore decrease mortality. If an ACE is prohibited, then an ARB can be used. Some other heart failure treatments include regular exercise, a cardiac rehab program, sodium restrictions, fluid limitations, discouraging alcohol consumption, assessing daily weights, and for a 3-pound increase greater than 24 hours or 5 pounds in a week, notifying providers, and being immunized with the flu and the pneumococcal vaccinations. Okay, let's talk a moment on arrhythmias. Arrhythmias are something that are maybe first seen by a primary care provider, and those could include your atrial arrhythmias, AFib, atrial contractions, atrial tachycardia, atrial flutter, and SVT. Some ventricular arrhythmias include PVCs and ventricular tachycardia. You may see first, second, and third degree heart blocks and arrhythmias associated with digitalis toxicities or other medications that are commonly seen. So some diagnostic tests that you would do for an arrhythmia will start off with the basic and EKG that will determine the type of arrhythmia that will help guide treatment. Electrophysiological testing using an intracardiac electrocardiographic recordings is used to diagnose and manage complex dysrhythmias and can also evaluate recurrent syncopal episodes of possible cardiac origin. And these tests also differentiate supraventricular from ventricular dysrhythmias. A tilt table is useful in patients with arrhythmias when syncope may be due to a vasovagal response. And then there's the transesophageal echocardiography where a probe is put down into the esophagus to see the heart from the backside. Management of AFib, the goal of the treatment is to control the ventricular response and convert the patient back to normal sinus rhythm by using medications or electrical synchronized cardioversion. These drugs include amiodarone and disopyramide. Um, Digoxin should only be used as a second line agent. Um, elective synchronized cardioversion is recommended if acute ischemic heart disease is present, along with a rapid rate anywhere in the 200 range, or if the patient is in clinical distress, 120 to 200 beats per minute. Um, Before electrical or pharmacological conversion is attempted, anticoagulation should be considered. Anticoagulation should be initiated in all patients who remain in AFib longer than 48 hours, who have experienced AFib for unknown duration. Patients may be placed on IV heparin for rapid anticoagulation and then started on Coumadin, which takes approximately 5 days to achieve its full anticoagulation. As we know, a PT-INR is drawn and the dose is adjusted based on this. The INR target rate for AFib is 2 to 3 times, and the INR should be checked at regular intervals. Alternatives to warfarin may include your Pradaxa, your Xarelto, or your Eliquis. These agents are used for the management of patients with non-valvular AFib, and these drugs have a shorter half-life, fewer drug-drug interactions. They peak earlier as compared to warfarin, and the newer agents do not necessitate dose titration or lab monitoring. However, one of the disadvantages of these drugs is that there is not an established antidote for reversal of the symptoms. So that's important to take into consideration. Um, let's talk for a moment on premature arterial atrial, premature atrial contractions. And treatment for these is usually not needed unless the patient is symptomatic or there's an underlying cause that can be corrected. It's often seen in young, healthy individuals and may be induced by stimulants. Often, stopping tobacco or reducing caffeine intake can decrease the incidence of PACs. And if there's continued symptoms, a Holter may be added to assess. For SVT, the initial treatment consists of a vagal maneuver, and these are techniques such as coughing, lying on the floor while elevating your legs against a wall, or squatting. These maneuvers increase the parasympathetic tone and slow conduction through the AV node. Also, you may see facial immersion in cold water as another method that slows this transmission through the AV node. Paroxysmal supraventricular tachycardia treatment is using adenosine 6 milligrams given as a rapid IV push. If treatment is unsuccessful and the dose is increased to 12 milligrams and may be repeated one more time. Adenosine blocks the AV node and has an extremely short half-life of less than 10 seconds, but because of this short half-life, it's critical that the drug be delivered very rapidly, followed by a rapid saline flush. And you can read the rest of the slide here on some different treatment options. So for PVCs, we usually see these in healthy individuals that require no treatment unless we're trying to treat an underlying cause. Stopping tobacco use, caffeine, improving electrolyte imbalances may reduce the incidence, and if the issues persist, Holter monitoring again may be needed. For our heart blocks, we have Mobitz 1, and Mobitz type 1, which we typically just observe. If there's severe bradycardia, a temporary pacemaker may be needed. For Mobitz type 2, a permanent pacemaker is usually necessary, and a third degree block is a medical emergency and potentially life-threatening, and would require a visit to the ER. For valvular disorders and murmurs, mitral and aortic valve disorders are the most common. They may be congenital or acquired, and also may be symptomatic or asymptomatic. Heart murmurs, or the sounds, as we all know, is that turbulent blood flow. So on systolics, they can have a graded murmur of anywhere from 1 to grade scale on 1 to 6 on the scale, from barely audible to audible with a stethoscope off the chest, and grades 4 to 6 must have a palpable thrill. Diastolic murmurs are graded on the same scale, but they're from 1 to 4 because these murmurs are not loud enough typically to reach grades 5 or 6. More on murmurs, you can have benign systolic ejection murmurs, which are physiological murmurs found in the absence of cardiac pathology in up to 80% of children. You may see it in up to 80% of children and also in thin adults. If the cardiac exam is performed in a very quiet room, it's best heard at the left sternal border and occurs during early to mid systole. Hemic murmurs are heard in high volume states such as anemia, fever, response to exercise. This murmur is a crescendo to decrescendo, and it's harsh in nature, and there's no cardiac pathologies associated with this condition. It resolves when the underlying cause is gone. And for aortic stenosis murmurs, also called a 50-50 murmur because they're present in 50% of adults older than 50 years old. Its etiology is fibrotic or a calcific change to the aortic valve. Next, we're going to talk about valvular disorders, and mitral valve prolapse is the most common valvular heart problem and occurs in 2.4% of the general population. In most cases, it's considered a benign condition. However, mitral valve prolapse with mitral valve regurgitation can predispose someone to have blood clots and endocarditis. Mitral valve prolapse can be associated with a mid-systolic click and a late systolic murmur. You may find palpitations. To help diagnose this, an echocardiogram, Holter monitor to rule out arrhythmias. In mitral stenosis, it's usually the consequences of rheumatic fever. It progresses to pulmonary hypertension and right heart failure. You can have diastolic murmur, which is best heard with the patient in the left lateral decubitus position. And for patients with symptomatic mitral stenosis, a sodium-restricted diet should be started to reduce blood volume and pulmonary systemic venous pressure along with an anticoagulation. In mitral regurgitation, you can have shortness of air. Shortness of air on exertion, palpitations, or noted symptoms on decreased exercise, and have an intolerance there. You can have a holosystolic blowing murmur at the apex. You can have a transthoracic echo, which is a diagnostic test of choice. And for acute mitral regurgitation, this can be a medical emergency and surgery is required. For chronic that is asymptomatic, just close monitoring. Or for chronic that is symptomatic, you would have them on an ACE, a beta blocker, and diuretics as your treatment of choice, and then your treatment of choice would be surgery. So, continuation of the valvular disorders for aortic stenosis, shortness of breath with exertion, angina, or syncope. The murmur is systolic, mid to late, peaking with a crescendo-decrescendo pattern. Diagnosis is made with Doppler and is usually seen in those greater than 60, those that may have had rheumatic heart disease and chronic kidney disease. You can also see complications of acute CHF and sudden cardiac death in symptomatic patients. Aortic regurgitation, you can have palpitations in CHF, have a diastolic murmur. Diagnostically, you would use an echo. For acute symptoms, an emergency requiring surgery, and you see it. Risk factors would be for those that have had rheumatic fever, endocarditis, Marfan syndrome, or related connective tissue diseases. All right, on peripheral artery disease, some of the symptoms are the 6 P's, which include pain, pallor, pulselessness, paresthesia, paralysis, and poikilothermia, which is coldness. Sorry about the pronunciation on that one. Symptoms can be intermittent claudication, pain at rest, usually no swelling, and eventually you develop purplish coloration of the lower legs and ankles. Diagnostically, you would have them have a Doppler flow with a calculation of their ABI, and perform a walking impairment questionnaire. And I'm going to show you that on the next slide. So these are some questions that you might ask if you had a patient that was presenting with symptoms that you were concerned of for peripheral artery disease. And that's very easy to obtain on the internet. The management of these patients is the goal is to improve blood flow to the area and decrease the cause of the impaired circulation. So patients should be counseled about modifications of risk factors such as hypertension and diabetes. These should be aggressively managed. The patient should be encouraged to walk at least 30 minutes 3 to 4 times per week. Legs should be kept dependent to improve blood flow and therefore bring more oxygen to the extremities. Tight stockings should be avoided. Antiplatelet therapy should be started with aspirin. When they cannot tolerate aspirin, then placing them on Plavix. Surgical interventions and angioplasty are used selectively with patients with severe PAD, so a referral to a vascular surgeon is important. And then we're going to talk about DVTs. So DVTs are disorders of the venous system characterized by a clot formation in the deep vessel. Chronic venous insufficiency is a disorder that is seen with valvular incompetency, which can lead to lower extremity edema, skin discoloration, and ulcerations of the lower extremity as a result of decreased venous flow. And although this condition is commonly seen as a complication of DVT, it is a result of an inflammatory condition such as phlebitis or an anatomical disturbance. So the patient that presents with complaint of pain in the calf, such as slight swelling or muscle tenderness, if a DVT is suspected, the patient should be assessed for a clinical pretest to check for the probability of a thrombosis, and this can be done with a probability assessment such as the Wells criteria. And if the patient is determined to have a low clinical probability of a DVT, then a D-dimer may be ordered, or if the patient has an intermediate or a high clinical probability of a DVT, an ultrasound of the lower extremity should be obtained to confirm diagnosis. I know you're glad that we're getting to the rest of this because I'm becoming very tongue-tied. DVT management is typically done for a new onset, initially treated in the hospital, but can be treated as an outpatient. Low-dose heparin, whether it's in the outpatient or inpatient setting as an IV, used anywhere from 1 to 5 days. Lovenox can be dosed as sub-Q every 12 to 24 hours. For 12 hours, it's 1 milligram per kilogram per day, and to be dosed every day, every 24 hours, it's a 1.5 milligram per kilogram Q-day. Coumadin is usually started while the patient is on heparin, and you start at 5 to 10 milligrams daily. Recheck their INR in approximately 3 days, and your goal INR is anywhere from 2 to 3. Once this is reached and maintained for 2 more days, then the heparin can be stopped. For DVT management, anticoagulants should be used for at least 6 months following an initial first episode. Additional episodes require Coumadin up to 1 year. If an additional clot was noted, then I think it's important also to possibly do some coagulation studies to try to rule out some other conditions. You need to check the INR every 1 to 2 weeks until the patient is maintained at target, and then every month and as needed. It's important for these patients to avoid mobility. We don't want stasis of blood in the venous system, which could lead to increased clots. It's important to exercise. It's also important to warn patients about drug interactions, whether it be over-the-counter or prescription. A big one that patients should be concerned about is cold medications, antibiotics, aspirins, Tagamet, some other NSAIDs. It should be stressed to the patient that there is a very high need for follow-up for patients that are on warfarin, and if your patient is on warfarin, I typically do not give long standing prescriptions for patients on warfarin because their medications are adjusted so frequently and warfarin is not expensive. But keeping your medications to, especially for Coumadin or warfarin, to a 30-day supply will get them back in, or at least getting them calling, and you can get them back in for follow-up. There are some places that have Coumadin clinics that help with the management of these patients if that is something that you're not able to do in your practice. So, okay, we're at the end of chapter 10 for cardiology, and if you should have any questions, please let me know. Thank you.